ladies and gentlemen, we go by the name Fusion 520. The first song that we're going to perform to you, it's a song called Maruje. Maruje is a love song for the man who's just trying to love, like Maruje, my love, where are you? So, ladies and gentlemen, enjoy. Uri kupikani maruje, oh maruje, uri kupikani maruje, oh maruje, 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 oh maruje, 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 oh maruje, maruje, maruje. Merci. On attend la mise en fonction de la vidéo de ICASA. Merci à... Non, après c'est toi qui viens avec moi, je vais t'appeler. Non, tu vas aller avec tes gens. Merci, bonjour et bonsoir à tous. Très honoré ce matin de recevoir l'invité d'honneur. ICASA.
International Conference on the AIDS and STIs in Africa.
Eliminating AIDS. 33 years out. Brick by brick. Celebrating. Célébrer. 33 ans. Éliminer les AIDS. Brick by brick. From the DR Congo, we decided that AIDS would be no more by the year 2030. So far, so good, and today here we are. Mitigation of disease, collaboration in the region, promotion of research, elimination of AIDS. ICASA. 33 years out. ICASA. Brick by brick. ICASA. Celebrating. ICASA. Célébrer. ICASA. 33 ans. ICASA. Éliminer les AIDS. ICASA. Brick by brick.
The Society for AIDS in Africa, founded in 1989 at the 4th International Symposium on AIDS and Associated Cancers in Africa, now ICASA, held in France by a group of African.
L'honorable ministre des Affaires étrangères et du Commerce international, Dr Frédéric Chaba, nous vous saluons. L'honorable Dr Douglas Temombe-Chora, ministre de la Santé et pour les enfants, nous vous saluons également. L'honorable Dr David Paris, président de la Société africaine anti-sida, et tous les membres du board. L'honorable différents ministres, les responsables des agences du système des Nations Unies, les participants de ICASA, distingués invités et ladies and gentlemen, sans oublier notre ami Peter Ndjan qui représente la communauté, nous vous saluons tous. Merci d'être présents pour honorer cette cérémonie de fin d'ICASA au Zimbabwe. Le programme, monsieur l'honorable, est le suivant. Bientôt, nous aurons la session des rapporteurs. Et après la session des rapporteurs, nous aurons le mot du représentant de la communauté, de la société civile. Après, nous aurons les mots de clôture de David, président de la Société africaine anti-sida. Après, l'honorable ministre de la Santé va faire son mot et introduire le ministre des Affaires étrangères. Et le mot de la fin, pour clôturer la cérémonie, serait prononcé par l'honorable Frédéric Chaba. Donc, sans plus tarder, permettez-moi d'appeler un homme qui s'est battu pendant des années, qui fut volontaire pendant 10 ans, de 1995 à 2005, au niveau de la Société africaine anti-sida. Et qu'à partir de 2015, fut recruté comme directeur de la Société africaine anti-sida. J'ai nommé M. Luc Bodea. M. Luc Bodea a un master en management des conférences internationales. M. Luc Bodea, vous êtes invité. Ensuite, j'appelle mon colonel, le colonel-major Alain Adzekondo, le rapporteur général, avec ses rapporteurs, qui doit être là pour nous parler vraiment de ce qui a été, pour nous résumer, ICASA. Mais Alain est un pédiatre. C'est un pédiatre, c'est le tonton, le papa des enfants, mais c'est un acteur chevronné, un père reviveur, un reviveur des abstracts. Et depuis 2015, il est devenu coordonnateur, rapporteur général des conférences ICASA. Alain. Merci. Donc, M. Luc Bodea, Je vous donne la parole pour nous camper un peu le décor. Quelle a été l'ambiance de cette ICASA? Vous avez la parole.
Thank you so much, Mr. Chair. Let me take the opportunity to once again thank all the participants. Without you coming here, we will not talk about ICASA 2023. There is no ICASA without participants. And this time around, we have noticed that at the community village, we have more than 1,500 participants. At the registration site, in person, we have 6,856 participants. Virtually, we have 1,275 participants. The total participants for this ICASA Zimbabwe 22nd edition is 8,118 participants. As we are talking about participants, it's very important that we should talk about the scholarship. It's important to understand that the government of Zimbabwe gives 500 scholarships to the local people. On top of that, ICASA gives 200 scholarships in person. And we give 1,571 scholarships. This year, we give a total of 1,771 scholarships. It is also important to notice that in terms of abstracts, we receive 2,600 abstracts and 2,540 was reviewed. 1,747 was rejected, and to run this ICASA 2023, we run it with 78 oral abstracts. We also run it with 115 posters. Let me conclude, Honorable, to say that in terms of program, for the 5 days, we organized 182 sessions with 546 speakers coming from around the world. We even have speaker Pakistani here, for Pakistan here. And we run also 27 sessions at the community village alongside with the 9 community networking zones. Once again, as I said, without participants, without delegates, there is no ICASA. I just want that you should give yourself one round of applause because you have been wonderful. Thank you so much.
Merci le maestro de la SA. Maintenant, nous donnons la parole au colonel Alain pour introduire les différents rapporteurs et faire le résumé devant nos illustres hôtes. Alain, vous avez la parole.
Honorable ministers, president of this conference and also the director of this conference, all protocol observed. Good morning, everyone. Mamukase. I hear that I have many of my people coming from Bulawayo, and I will say Levuke Njani. Thank you for coming to this session. And in Shona, I started learning since 2011. I can say Chinoku Gashirai. In this session, I'm going to invite speakers to present the global statistics and findings from track A track B, track C, track D, track E. Those tracks cover the scientific program. And also, we have the privilege to receive also rapporteurs for community program. But let's start by introducing the assistant of the lead conference rapporteur to show us the big data. The director of this conference show us also big data, but we are going to present also some big data. This big data will be presented by Dr. Yevedo Tohojede, who is a lecturer in nephrology pediatrics at the University of Abomey-Calavi, Benin. Please, Mr. Yevedo, you have the floor. The first presentation, this track I. First presentation. Thank you very much, Aitabasa.
Thank you, the lead conference rapporteur. Good morning, everyone. It's my pleasure to present you the global status of this conference. Next slide. For of us, I would like to show with where we were organized to do these reports. At the leadership, we have both the chair of scientific program, Professor Mike Chiringer, and Mr. Luc Baudéa, the director of this ICASA. We have also a coordination team with a Commodore Alain Azondecan, the general rapporteur of this conference. His assistant, myself, Dr. Tohojede Vedo, and Mrs. Isabelle Baudéa, logistic officer. And then our rapporteurs of track A, B, C, D, A, and the community program. We started by having 2 days of training with a specific objective through 8 lecturers and 9 tools. We were 26 rapporteurs, 16 coming from Zimbabwe and 10 from France, Côte d'Ivoire, South Africa, Tanzania, Ghana, and Benin. What did we? Next slide. Next slide. What did you achieve so far? We did find to all plenary, abstract section, and special sections. We did also great at the community village, has only 4 activities didn't happen. As you can easily see that the non-abstract driving and workshop section were completely done. Only 1 section of satellite didn't happen. All share. Next slide. Next slide, please. All share invited came, except 8 share missing, but they were replaced. Regarding Regarding these results, we can congratulate ourselves that this performance was good. Next slide. Look at this photo group of reporters. It can be easily noted that we faced difficulties and challenges and working in friendly environments, sharing our African value to fight HIV and AIDS. Next slide. Thank you for your attention.
Thank you, Dr. Adevedo, and let me come back on this last photo that expressed the value of Africa. We came from various countries, and then we work together in very safe environment. So now, let's move to the speaker of track A, a very challenging track in our environment, basic science, biology, and pathology. I will call here Dr. Adrian Moodley, who is medical doctor in Cape Town, South Africa, who specialized in forensic pathology and now runs his own practice. He has a special interest in patient for HIV patient and HIV-based research. Please, Moodley, you have the floor.
Good afternoon, everybody. Track A. I hope everyone can understand my accent. I'm Dr. Adrian Moodley. I'm from sunny South Africa, Cape Town, the city by the seaside. I do hope to see you guys there. Next slide. I'd like for you to meet my team. Without these men, it would not have been possible to give this report. If you were looking for more flattering versions of them, they're sitting in the couches over there. Mr. Tinashe and Dr. Allen were invaluable to making this presentation happen. And both of them are biomedical scientists at the university. So I thank you for your help. Next slide. When we looked at the sessions that Track A covered, what we noticed is that there were 4 overarching trends across all of these sessions. Namely, there were HIV itself and associated infectious diseases, the widespread acceptance of self-testing, vaccinations, the need for African-based development of our own vaccines and HIV vaccine research, and what lessons we could learn from the pandemic and how ready Africa is should another pandemic occur. We'll go to the next slide, please. So, what can we say? There has been a general decrease in the HIV infection rate since COVID-19 pandemic, but the burden still remains high. With that in mind, we had experiences shared from Zimbabwe in their HIV prevention cascades, which re-emphasized the age-old philosophy that prevention is better than cure. What we also noticed throughout 2 sessions is there's an alarming rate of drug-resistant HIV variants. 2 studies from Benin and Cameroon were able to confirm this, and this places emphasis on genetic monitoring and an increased amount that's needed for testing for resistance. On a side note, a study from Kilimanjaro found 55% of women living with HIV were co-infected with bilharzia. This raises the question of an increased need for screening, as well as a study that should be done on what is the burden of co-infection of bilharzia in HIV patients. Next slide. So, the next session followed a really large study which reviewed the development of vaccines for the 4 major treatable STIs, as mentioned in the picture. In that session, we were able to mathematically calculate that even a vaccine with a limited amount of effectiveness will have a significant decrease in the incidence of the 4 major treatable STIs. And in some cases, like syphilis, it was extrapolated that it can actually be eradicated. Thus, this means that vaccine research towards these STIs should definitely be prioritized. However, what we did notice is that most of these trials were performed in developed Western nations, such as New Zealand, Finland, and Europe. Africa needs to be involved in STI vaccine research, and there's a need for these trials to occur here. Next session pointed out that the HPV vaccination program has been rolled out in over 136 countries. That's fantastic. However, we use the 2-dose regimen, which introduces 2 doses of complications. Developing the vaccine wasn't really the problem. The problem is getting the vaccine to the people who need it the most. As such, several countries we've noted have decided to change to a single-dose regimen. Experts from these sessions warn against this, as limited evidence exists if a single dose is going to be effective enough to successfully prevent HPV. A session on mRNA vaccines was hosted, which shows a South African company, Afrigen, making new technology available for mRNA vaccine development. This is specifically marketed to low and middle income countries, in other words, the African context. This will allow local vaccine development. This should not be overlooked. Next. In the thread of rise of self-testing, we've noted that blood-based kits have been placed out and they are widely accepted by consumers across all of Africa. There's some experiences that Uganda and Nigeria shared that make leaders beware of cheaper, unapproved tests. The tests should be more available. You should be aiming for supermarket shelves, not just your pharmacies. And always remember, price is king. Aim and target your consumers for self-testing. In another session, viral hepatitis has been noted to be on the rise. In order to successfully eliminate viral hepatitis by 2030, the secret isn't to treat it, rather to increase detection and screening. As such, the self-testing kits will definitely help in this regard, and there's a need to roll it out to the lowest possible level, i.e. right at mobile clinics. Next slide. In the thread for vaccinations, we've got a couple of new findings. A detailed South African review showed we were able to rapidly develop our own COVID vaccines during the pandemic. And the data was analyzed to show that, yes, indeed, vaccines and their boosters do work. There is yet at the moment no effective HIV vaccine, but the search continues. Trials and testing, therefore, is emphasized to be within the African continent. A next session showed that HIV vaccine research is hampered by inadequate funding. Ladies and gentlemen, honored delegates, none of the analyzed African countries met the 15% GDP allocation for health and research and development, even though we publicly committed to the Abuja and Bamako commitments in 2002 and 2020, respectively. Domestic funding is critical to advance research and development in Africa. We have failed our promise. We shouldn't be relying on handouts from Europe. Next slide. So, in our last thread of lessons from the pandemic and the state of readiness, the Global Preparedness Monitoring Board, GPMB, have pointed out very blatantly that Africa is not ready for another pandemic should it come. This is alarming and needs to be addressed. They've identified that the core problem is a lack of accountability and leadership. Therefore, they recommend target setting as an easy solution, but effective first step, such as 95, 95, 95 goals that are easily understood and can be measured. Next slide. So here's a couple of takeaway recommendations from track A. Active monitoring and testing for resistant strains. We've noted a widespread resistance to NRTIs and NNRTIs, of which track B will elaborate on. Self-testing is effective, it works. Focus on the consumer for these kits. Next one. South Africa needs to be, or Africa needs to be the focus of vaccination development. STI vaccines are effective, we should be rolling them out. Self-made vaccine production needs to be prioritized. The mRNA technology that I explained that Afrigen was making available is aimed to be affordable. We should not leave this option unexplored. Next slide. Finally, Africa is not prepared for another pandemic. We haven't fulfilled our mandates to the Abuja and Bamako commitments. We need to focus on developing Africa's ability to resource itself. We shouldn't be depending on our international partners. We have a lack of strong leadership with accountable targets, because what if another pandemic occurs? Once again, it can be noted that there's a limited number of science and pathogenesis-based studies that were given to the track. There's a direct need for more science-based studies to be performed, because as you can see, some of these trends overarch into track B and C. So with that in mind, I will hand over to track B.
Thank you, Modley. Now it's time to present findings of track B, namely clinical science and treatment. And I will call Dr. Akogen Avelin, virologist working at the Institute of Research and Development at Montpellier, France.
Thank you very much, Alan. I would like to first thank the ICASA organizing committee and its director for inviting me for this conference. It's a pleasure for me being here, and I'm going to give a short talk on what we have recorded for track B. And first of all, I would like to thank my two colleagues who work with me on that track, Dr. Chikombo and Dr. Tavenga. I thank you very much. Without you, this work would have been not been possible. Next slide, please. So in this track, we recorded about 21 sessions and almost up to 60 presentations covering treatment and care and clinical science with 4 major key points on treatment optimization, especially in the pediatric populations. Issues of how should we improve treatment outcome and the major related challenges around adherence and retention into care, and also improvement of treatment of other comorbidities as co-infection, TB, cryptococcosis, meningitis, and we had few sessions on other viral infections as viral hepatitis. Next slide, please. So the major highlights that we would like you people to bring at home regarding the clinical science and where are we with treatment and its outcome in the continent is that, first of all, there were many sessions and many presentations on the key populations that pediatric and children, adolescent almost represent. It was noted and acknowledged by many presentations that there are still important gaps remaining between infants, children, access to care, and adults, and that should be corrected. And to reach that, it was recognized that innovation should be the key, especially in terms of developing new treatment strategies, ART combinations. Should we consider only the dolutegravir approach, or should we look for other options? Monoclonal antibody should be also put into the package, more accessible and more affordable, and also new pathway to treatment as long-acting drugs. And Linda's talk on during the plenary very well allied that fact. Slide, please. Still on this way, in the pediatric domain, the question of how should we better prevent new infections in women and children was also one of the major issues. And the discussion around should we introduce PrEP for pregnant women and breastfeeding women were discussed. And overall, it was recognized that we need to move to more equity and justice for women and children in what we are doing to move toward the elimination. Next, please. Key populations, as we know, we have recognized many years ago that if you want to really eliminate HIV/AIDS, we need to focus on where are the epidemic features still going on, especially transmission, high incidence rate, and so on. And key populations were also discussed here. Advocacy for adapted treatment for this population were also raised out in the presentation with several studies discussing original approaches. We had studies from Senegal in injectable intravenous drug users with specific programs that were put in place to see how this population can better catch up and monitor and also have access to treatment and monitoring. Better prevention strategies should also be developed in this population, not only for HIV/AIDS, but also for other infections. Studies for IET, for example, show that even though hepatitis B and C prevalence were low in the population that they were in the key populations that they were following, they had a lot of issues in terms of coverage of vaccination for hepatitis B, showing that there are still improvement in this domain. Next, please. So we still have a lot of challenges, although many progress has been done to move to the goal of elimination. And there are still key points as how should we tackle the bottleneck of low adherence and retention in care, which is recognized as one of the major problems to achieve good treatment outcome. And there were new strategies and experience shared by different research groups as the daily management, psychological follow-up, and so on, not showing only increase in adherence and retention, but also on viral load suppression with good results. The question now is to see how that can implement it in other settings. And also different work were presented on the other issues that we are facing and we are going to face. The scale up of ART and the fact that people are getting better is the fact of aging. People who are treated are living longer, and we are having a new population with new problems as non-communicable diseases and other challenges that the services and the program are going to take into account. Next, please. These challenges also include, as my colleague just said, the fact that drug resistance remains one of the key limitations, and not only HIV drug resistance, but AMR in general for other infections, bacterial infections. That was observed in studies here in Zimbabwe. We still have issues, the dolutegravir drug resistance. We know that the genetic barrier is high, but however, we do have mono and B therapy due to the fact that the backbone is NRTI, and that should be improved too. Then we need to improve surveillance for that. The tools were presented in the track A session with new genotyping assays, but the question of the access and the cost of this testing remain a major point. And we should improve pharmacovigilance for the dolutegravir, although we know that some issues as the neural tube defects are not still a key problem, but we do have other problems as the weight gain for people under the dolutegravir. Next, please. And finally, we have comorbidities that should be managed better, TB and other infections. We recognize that TB is still a major issue in Africa. There are still some, what we can call some niche with dissemination ongoing by the missing population. And we need to improve, especially for the pediatric. There are new tools for diagnostics that are going on to help improve the diagnostics in pediatric, as the nanotechnology or point of care ultrasound that were presented in the conference. And regarding other key diseases as cryptococcal meningitis, there were studies presented to show how we can improve treatment by new combinations, which can be better in terms of cost and in terms of simplification of treatment. And on that, I will thank you for your listening. And
thank you, Avlen. Avlen is one of my rapporteurs that have devotion. He was supposed to be at the airport, but he decided to present this report before moving to airport. So, Avlen, safe journey back home. Thank you. Now it's time to introduce my colleagues, Dr. Huguette Kimbo, who is the research director of Elizabeth Glaser Pediatrics AIDS Foundation in Côte d'Ivoire. She's going to present the findings on epidemiology and prevention. Please have the floor. 7 minutes.
Thank you, Alan. Bonjour. Hi, everyone. Next slide, please. I would never have been able to present this work to you without my great team, Dr. Grant, Dr. Pari-Renyatwa, and Mrs. Gombi. We are sitting there all from Zimbabwe. Next slide, please. In this track, we cover in total 36 sessions, but we have more than 90 presentations. Next slide. What could we say about epidemiology? HIV/AIDS remains a significant global health challenge according to all the reports that we cover, and the key population remains disproportionately affected. Women living with HIV have 6 times higher rate of cervical cancer than HIV-negative women. And regarding pediatric, HIV/AIDS is still far from being controlled in sub-Saharan Africa. Indeed, 90% of all new pediatric and children HIV infection occurred in sub-Saharan Africa, and the majority of HIV/AIDS-related deaths among children and infants occur in sub-Saharan Africa also. And it was reported that there remain 20% gap in treatment between adult and pediatric population, and there is a lack of easy access to early infant diagnostic and point of care tests for children. Next slide, please. Regarding prevention strategy for HIV, we noticed 35,000 new HIV infections among adolescents and young people in Mozambique with low condom use. And also approximately 2 million of condoms are used in Uganda, what we see in some studies. About NCDs and HIV/AIDS, cardiovascular disease are prevalent among people living with HIV in Zambia, with 21% of people living with HIV over 50 years. Next slide, please. Now talk about prevention science regarding advancing integrated biomedical prevention services for VMCC, voluntary medical male circumcision uptake among adolescents in Zimbabwe. We have 98% of acceptability and 81% choose the shunt over surgery. And the Zimbabwe, through a number of studies conducted, has also shown that the Shangri device could play an important role in boosting demand for circumcision in future efforts for VMMC. Regarding the step care approach, defragmenting digital, sexual and reproductive health and rights for young people is really, really important. And also, we should help to provide essential and reliable health information and services and specialized support from professional healthcare providers such as psychologists. Next slide, please. Oh, also the adolescent and young, the previous slide, please. About adolescent and youth, we highlight that we have a key group for epidemic control. Adolescent girl and women are a vulnerable group to the treat sexual and gender-based violence and unwanted pregnancy. Now we are talking about the PrEP. And some studies in Kenya and South Africa highlighted that the success and acceptability of PrEP delivery through private pharmacies is really important to talk about. And we have also significant gaps in awareness and knowledge of PrEP, including shingling and long-acting injectable carbotigarin were noted in communities. About stigma and discrimination, because we talk a lot during this track. The magnitude of HIV and other STIs among key population in sub-Saharan Africa has been difficult to estimate due to the significant barriers such as restrictive legislation, stigma, and social discrimination. Next slide, please. For the recommendation that we have on prevention, strategy, and intervention, shingling was demonstrated to be a safe option for adolescent boys in Zimbabwe. Government youth should take up VMC by civil society organization. And the fourth 95% will become critical as people living with HIV/AIDS. It's important to say that. About integration of services, integration of NCDs into HIV care is not only about funding, but building simple diagnostic into treatment and care. And the key population, we should include gender-affirming servicing and trans-affirming language in health services to improve cervical and prostate cancer screening update. Next slide, please. I cannot end my presentation without talking about the new W 2023 recommendation about the self-testing, also some update that we have. Next slide, please. To end in pediatric and children by 2030, we need comprehensive policies, strategies, funding, and services. Optimizing community involvement to improve how KPs can be treated and represented is really important. Also, the epidemic control cannot be achieved without moving the KPs as a significant stakeholder. And the last word, to end AIDS by 2030, there is a need to maximize the use of digital technology, including artificial intelligence. Next slide, please. Thank you.
Thank you, Marie-Liguette. Now we are going to share with you the findings in health system, implementing science. No, please. I am going very fast. So let's introduce my colleague, Dr. Kingsley Mort. He's a social scientist and lecturer at University of Ghana in Legon. He's going to share with us the findings in social and political science, human rights, and then law. Please, my boss.
Morning, everyone. This is track D, and for track D, we looked at issues of law, human rights, social and political science. And I had a wonderful opportunity to work with a gallant team from Zimbabwe here. And for the past few days, we have supported each other. And the findings I share, I attribute it to their hard work. For our track, we had a total number of 34 sessions. We had 11 speakers or presented, 111 presenters or speakers. Those who came were 104, 7 were absent. We had 40 chairs, 35 were present, 5 were absent. Regarding the theme of this conference, we realized that remarkable progress has been made, but there's a global increase in new HIV infections among young people. So even though COVID happened and were restricted, HIV infections were still going high. And key populations continue to be disproportionately affected: lesbian, gay, bisexual, transgender, and queer persons, persons with disabilities, people who use drugs, prison inmates, sex workers, young people, especially adolescent girls and young women. At least 2/3 of adolescents are on antiretroviral treatment with viral load, and about 1.65 million adolescents last year are still living with HIV and AIDS. Clearly, what this means is that AIDS is not over. Key populations have been systematically and judicially persecuted or discriminated against. If you take, for example, South Africa has the highest coverage of social protection. Social protection is a human right, but key populations are not benefiting. At the workplace, in employment, housing, and health centers, key populations are discriminated against. And this is not considered acceptable on a human rights basis. We do know that some African countries have made remarkable progress regarding having laws or policies to stem the tide of stigma and discrimination. But some African governments have not shown enough commitment to discriminate same-sex relations and sex work. There are some countries that are enacting anti-rights laws, and this is rolling back the gains in human rights. The case of the Ugandan law is an example. In this conference, it was clear that engagement of youth in program processes leads to sustainable development. And all presentations from the youth and key populations tended to point out the fact that they need to be meaningfully engaged. They need to participate at the program design level, implementation, and monitoring and evaluation. Why? It will drive the process of HIV/AIDS interventions. So there's a need for a paradigm shift that young people and key populations should be meaningfully engaged. In this conference, we have seen that a lot of UN agencies continue to make remarkable progress towards ending AIDS in children by 2030, particularly UNAIDS, the WHO. But last year, children accounted for 13% of global deaths due to HIV. What this means is that obviously children must not be left behind. In the maiden report of the stigma index, internalized stigma was very high. It scored 84.8% among key populations. The implication of people living with HIV and AIDS who hide their HIV status can be affected by depression, stress, and social isolation. Keeping one's HIV status secret limits access to life-saving treatment and presents adherence challenges. The UNAIDS highlighted inequalities as driving HIV/AIDS in Africa, and presentations demonstrated the fact that there are socioeconomic inequalities between males and females. And females, young adults are more likely, between the ages of 10 and 19, are 11 times more likely to acquire HIV/AIDS than their male counterparts. Another key population that is worth mentioning in this conference that we covered is that high infections among prison inmates, and that people enter prison negative but leave prisons positive. This is an exclusively important population because they are underrepresented population. In this conference, we did not have the benefit of having prison inmates share their lived experiences. Again, exclusion race line, we found exclusion race line for persons with disabilities. Yes, a lot has been done in this conference to include persons with disabilities, but we had instances whereby there were sign languages as some signing, but in some of the session rooms, they are not accessible to persons with disability. And we also didn't have sign language interpreters in some of the sessions. In some African communities, influencers such as traditional and faith-based organizations do play a crucial role in the HIV response. Traditional or faith-based leaders are custodians of culture. And in the words of Minister Robert Sewanga of Uganda, he says that culture is born, culture grows, culture falls sick, and culture dies. What this means is that if we target the right people in society who are influencers, they can help stem the tide towards the fight against HIV. So to eradicate HIV/AIDS by 2030 is a duty for everyone. This is because all lives matter. Should key populations be left behind, the rest of society will become vulnerable. For this track, our recommendations include the fact that we need commitments to legal reforms and human rights. So there's the need to review laws and policies to address the specific needs of key populations. Regarding political leadership, like the SDGs and the UN AIDS goal of 95, 95, 95, African governments should set new targets upon which citizens can hold them accountable. Key populations deserve another chance. Citizens, communities, and political authorities should not assume the roles of moral judges. To conclude, this conference has recognized young people and key populations. We have seen young people and key populations as panelists, chairs, and facilitators. This is a recognizable commitment, and this must therefore be continued at an increased level. I thank you for your attention.
Thank you. Now, let's quickly move to the last track of the scientific program, track E, when we are going to present you the findings on health systems implementing science and economics. So this will be presented by Miss Olympia, who has 8 years of experiences in implementing donors fund program in Tanzania. Welcome to you, population from Kilimanjaro.
Habari za mchana, mabibi na mabwana. Masikati. Muri kunakizwa here. Oh, thank you. So my name is Olympia from Tanzania, and I will be presenting the summaries for track E, which is on health systems, economics, and implementation sciences. Next slide, please. Oh, okay. Okay. Oh, so this work was made possible in collaboration with my colleagues, Marijanatu, Anita, Daniel, and Tendai. And we expected 33 sessions, and all of them were conducted. All the presentations during the conference revolved around the WHO health system building blocks. So there's a PEPFAR symposium with panelists from Zimbabwe, Kenya, Ghana, and Tanzania that highlighted the importance of good governance and technical leadership. And they indicated that there should be a political will to engage the voices of the community, including decentralization and devolution. And this is a good approach to expand local actions on global commitments. Multi-sectoral collaboration to coordinate efforts and share resources was also mentioned in many presentations. Civil society and community engagement is an important aspect of health system strengthening, and a good example came from South Africa and Zimbabwe, who shared their experience on implementing community-led monitoring, and they highlighted the importance of implementing all the key components of community-led monitoring. Integration of HIV services and other services, for example, gender-based violence, sexual and reproductive health services, non-communicable diseases, neglected tropical diseases and cancers into primary and community healthcare services improves efficiency and is cost-effective. And this came out in many presentations. Data quality through robust data management system for M&E and surveillance is also crucial. And a good example came from Zambia, where they discussed on automation of HIV recent surveillance system to provide signals of the demographic groups and geographical areas with elevated HIV infection to inform targeted HIV programming efforts. With regards to implementation science, a symposium by the International AIDS Society indicated the need to increase population-level understanding of HIV self-testing, and also to promote greater use of self-testing in the community level, along with other targeted HIV testing approaches. A special session by WHO highlighted that countries have adopted the differentiated service delivery model. However, they have not fully integrated the WHO reporting indicators into their M&E frameworks. Reaching young people with HIV services is very challenging. But in Zimbabwe, a community-based digital screening tool known as Boost is helping address that challenge. A special session by transgender people highlighted that transgender people have the highest burden of HIV compared to the general population, And yet there is scarcity of data on this population, and that is a barrier to providing adequate health and psychosocial services tailored to them. So this highlights the need for more research and attention. Stigma and discrimination is a big contributor to increased HIV prevalence, and we need to address that. And a good example is a Ugandan faith leader who is with us in this conference, who helped address, Father Baguma, who helped address stigma and discrimination by publicly disclosing his HIV status. We need more people like Father Baguma. Faith leaders should be empowered on HIV and AIDS and other faith-related issues that are preventing the key population from accessing HIV treatment. With regards to health economics and finance, a plenary session by Global Fund indicated a widening HIV funding gap in Africa for various reasons. A special session by young people indicated that there is inequitable allocation of funding. Youth have the highest burden of HIV, and yet government and donors do not trust youth-led organizations and are seen as incapable of managing funds. There's also inadequate and erratic funding for community-led monitoring and other HIV interventions, such as voluntary medical male circumcision, sexual and reproductive health services, and management of advanced HIV diseases. A symposium by UNAIDS discussed on resource mobilization. To maximize effective utilization of resources, there needs to be a shift towards an integrated health service model. We need to integrate HIV services into national health financing, engage in public-private partnership, partner alignments to prevent duplication of efforts, and focusing investments where they make the maximum difference. A presentation coming from Kenya said we need to know our epidemic to know our response. Moving resources from programs that are not effective to HIV programming and task shifting, all these ones will help us to optimize the scarce resources that we have. Global Fund and UNAIDS also discussed on the opportunities for innovative resource mobilization, and they stressed that effective, innovative financing mechanism should be sustainable, progressive, stable, and efficient. And those mechanisms include debt to health, blended financing, social impact bonds, and other mechanisms such as direct health financing and community health fund that is implemented in Tanzania, Zimbabwe AIDS levy, and Botswana sin taxes, and also universal health insurance. Recommendations. Stakeholders are urged to fully adopt the district-based system approach for HIV service delivery, and countries should monitor and report the 5 minimum WHO priority indicators for DST. There's a need to adopt a whole school health promotion program using a participatory co-adaptation to increase GBV awareness. And also stigma and discrimination index data should be used to inform targeted interventions and also in the development of national policies against stigma. And countries should develop a sustainability roadmap for HIV services and devise innovations for domestic financing mechanism. So to end AIDS in 2030, African problems need African solution and financing. Thank you so much.
Asante Sana. Now, last but not the least, we share now the passion, devotion, and engagement of our community. I will introduce Mrs. Venus Mushininga. She's a pharmacist, MBA, MPH, a senior advisor at Elizabeth Glaser Pediatric AIDS Foundation, and former program manager at Ministry of Health and Childcare of Zimbabwe. Please join me to welcome Mrs. Venus.
Good afternoon, everyone. Good afternoon, everyone. Yes, thank you. Okay. Yes, I'm going to present the community program, the community track. All right, as we wait for the slides, I would like to thank my co-rapporteur, Sibongile Kimberly. She's seated right there, who facilitated this. There were two of us who were rapporteuring for that track, and there were 37 activities that we were supposed to cover, and we managed to cover the majority of them. All right, so there were different zones in the community village. We had the women networking zone, the youth zone, the faith-based organization zone, the key population zone, hepatitis, TB, and malaria networking zone, the people living with HIV zone, sex worker zone, and the diaspora zone. And I will say this was the heartbeat of the conference. It was all-inclusive. There was free access for all. Everyone from everywhere in the world could come and be part of the community village. The sessions had diverse structures, and there was a lot of music and dance and freedom of expression. So the issues with captures, there were tracks in the main conference as well for community. So the one issue that came to the fore was community-led monitoring. And it was clear from all the deliberations, from what we've summarized, that we need to adopt and use our community-led monitoring. We need to strengthen mentorship and capacity building for community members who participate in community-led monitoring, and simplify the technical language to ensure holistic and meaningful community engagement. For the community village, we had the persons with disabilities expressing their wants and their needs. So from what we gathered, communities with disabilities deserve inclusion, subsidized assistive devices, access to employment opportunities, access to education, a seat on the decision-making table, and disability-friendly infrastructure so that they can be able to access services. There were numerous platforms for community dialogue, where sex workers are actually reiterating that they matter in the fight to end HIV/AIDS in their sessions, and the women networking zone, where gender equity, inclusiveness, leadership, gender-based violence, sexual reproductive health issues were discussed, and other issues affecting women living with HIV and women living without HIV. And it was very clear that the voices of women matter in all the sessions, where we, as our conference participants in our places of work, we are recommending that we are expected to let women lead, allow them to sit at decision-making tables, and gender-based violence. And the women have expressed that our children and men matter too. We cannot leave them behind. And we need to address mental health issues and recognize the work that women do, the unpaid work they do, especially at community levels as caregivers. And it was also very exciting to be among the youth in the community zone, where the youth expressed that they want to lead as leaders of today and tomorrow. The youth deserve policies and legal frameworks that enable them to access our health services, holistic health services, an end to child marriages, access to timely and correct information, and they deserve to be heard and also sit on those decision-making tables, and they do not want to be judged. They're saying, please do not judge us. Accept us for who we are, the leaders of today and tomorrow. There were initiatives where the community was leading prevention, testing, and treatment, advocating for condom use, advocating for self-testing, and it was actually active provision of services as well. The faith-based organizations were part of the community village. There were sessions that were conducted there. And in summary, it was noted that we need to bridge the gap between faith and science. We need to harness the health expertise that is within the faith-based organizations through through appropriate collaborations, and we need to reach families and communities with public health interventions through trusted interventions within the faith-based organizations. And like I said, there was a lot of music and dance, as you can see from that picture. And we also did not forget that economic empowerment is actually critical for healthy communities. There was a mini market which was spread throughout the community village, and people could buy beautiful, beautiful wares. And I'm sure others are wearing the outfits they bought from the community village. Thank you for the support. And in conclusion, it is critical, and following up from the World AIDS Day theme, that we let communities lead. Because when communities lead, HIV responses succeed. And thank you in all the languages I cannot speak. Thank you.
Especially in French. Merci beaucoup. So, ministers, all protocol observed, we are at the end of this rapporteur session. Let me first recognize the work of my colleagues rapporteur. So they did a very great job. We worked in a very good environment, and we also have a good logistic support with one of our colleagues from the coordinating team. I will also say thank to those who stand for the leadership for this reporting. I will say the director of the conference who decided to send me 2 persons to cover the committee program. And as well, Professor Shirenji, he was yesterday with us 3 hours discussing and then giving us very relevant contribution. So thank you very much. I expected that next time when this conference will happen in Zimbabwe, I'll be here also. Thank you very, very much.
Merci Alain. Maintenant, la session des rapporteurs est terminée et merci vraiment des conclusions. Now, on va passer à un petit moment d'écoute de M. Albert Knight qui a fait un poème et qui va conclure la session des rapporteurs. Merci.
I-HIV ngoba siqhobe siqhunze siqothule ngoba singaba yinkani singaba siqhaqha siqhiye sichaye sicoce siqabe sixexebule i-HIV ngoba singaba yinkani singaba. Good afternoon, ladies and gentlemen. Ordinarily, we would have performed an ICASA song that I did with my friend, talented Derek Mpofu, courtesy of Luke. Unfortunately, there isn't much time. So, because I'm a TB champion, TB is one of those diseases that ICASA worries about. I'm going to do this poem. My name is TB. I am tuberculosis. I am a silent pain whispering through the air. I dance with death, and lungs are my greatest enemy. Your other body parts are not spared either. Like the stomach and the brain, I go for them too. I punch like a stapler. I am a death machine. Strife is my business, as your downfall is my happiness. I rob you of your beloved ones every day, and every day I spread my merciless wings to communities. I don't care who you are, where you live, rich or poor, black or white, child or adult, I am TB. I am everywhere, almost like the air you breathe. Millions lie on meds today from illnesses, and yet you guys can actually defeat me. Prolonged cough, chest pains, fatigue, weight loss, fever, night sweats. That's how you can identify me. When that happens, you must rush for TB screening, as my coughing, my sneezing, my spitting may easily have spread to you through the air. I am TB.
for I sprint like Usain Bolt. Miners, you can't escape my blow unless you have good ventilation. People living with HIV, my name is TB. I attack because your immune system is already compromised. Children under the age of 5, I am also after you, as I am after everyone else. If you are exposed to my teeth that never fail, my teeth that never miss, take TB therapy, TB preventive therapy. When caring for those that I have put to misery, wear a mask because I am TB. I attack especially the careless. When I spread my infectious fangs, you too can fight me by spreading infectious words with friends, with family, with neighbors, with peers, warning them of my vicious attacks and how you can break my wings that never fail. I am TB. If your governments commit funds to fight me, if your leaders commit more finances for treatment and research, you may win me over, but I'm no pushover. I am TB. I am merciless. I attack. Merci beaucoup.
Merci Albert. Maintenant, depuis le début de la conférence, nous parlons rien pour nous, sans nous. Sans la communauté, il n'y a pas de résultat. Et maintenant, nous donnons la parole à M. Peter Jan, représentant de la communauté, pour son mot. Applaudissez.
Good afternoon. Good afternoon. I'm Jambo. My community members, I'm Jambo. Guest of honor, Minister of Foreign Affairs, International Trade, Dr. Frederick Shava, Honorable Douglas Momboshora, Minister of Child Healthcare, Honorable Dr. Pangwesese, President of Society of AIDS in Africa, ICASA 2023, Honorable Ministers here, all AU agency represented, members of Diplomatic Corps, senior government official, participants, distinguished guests, ladies and gentlemen, and others, and my community members. I'm happy and extremely honored this afternoon on behalf of civil society and the key players present of the closing ceremony. My name is Peter Njane, a Kenyan gay activist and openly gay man. We are here representing gay men. We are
Behind me is the Vice President of SAR, who is here, Dr. Shakron. Next to him is the Secretary General of SAR, Dr. Sila Aliu. Then next to him is the Treasurer General, or the Treasurer for SAR, Professor Morenike. And next to her, next to her is the Vice Secretary General, who is also from South Africa, Dr. Fikile Ndlovu. So we cannot work without these people. They are the board of SAR, and I'm glad that you have come here. But clearly, I would like to recognize the person who is always on the ground, always wearing various costumes and various caps and various shoes. Luke Bodia, who is our director here, who knows exactly what's going on at any one particular minute regarding SAR. But we have got our trustee. I would like you to now go. I think you've been seen, yeah. Okay. We've got our trustee, Dr. Meskelem. Just stand and wave. And like I said before me, there was another president of SAR, Professor Idoko. Please just stand. Yeah, so that's the team, and those are the people who are here. Our journey started long back. The last SAR organized ICASA was in South Africa, in Durban, in 2021. You're all aware, ICASAs are held every 2 years. So the last one was in 2021 in Durban, and the next one is obviously this one that we're having in 2023. But as soon as we held the 2021 one, we started organizing for 2023. So this journey started as far back as that, to organize this particular ICASA for today, for the days that we have been here. And various countries bidded to host ICASA. Various countries within the Africa region, of course, bidded. And the one that won, without any bias, if I show you the marks, you'll be surprised. The one that won this bid was Zimbabwe. And that's why it is here. So I would like to thank His Excellency, the President of the Republic of Zimbabwe, for really embracing us, and pushing us, and encouraging us, and supporting us, and his government who have given us the protocol, the security, the transport, this venue, and other things that make a conference successful. Would like to thank that particular government for what they have done. The next stage that happened after we won the bid was to do various activities in between to make this a success. And the first meeting then within ICASA was held in Victoria Falls, when the first ladies came there and highlighted the issue of prevention of mother-to-child transmission. And this was led by our own First Lady, Dr. Auxilia Mnangagwa. And I would like to recognize in her absence that she did tremendous work for us. But having said that, the other First Ladies that came there, and that's why this conference is so successful, with First Ladies from Botswana, Mozambique, and Nigeria, who actually came in person. And then there were 3 other representatives of other First Ladies from Angola, from Egypt, and from Burundi. And that completed that. On top of the UN that was there. It was a very successful one, and a report will be tabled to the conference sometime later. After that, we had a conference here for the youth in this hall on the 4th of this month. That was the next stage, another high-level meeting of youths. And they voiced their opinion, and they emphasized that AIDS is not over, but put us in the forefront. And that, I think, I officially opened that particular conference. We're very happy with that. Honorable guest of honor, I would just like to highlight that when we have a closing ceremony like this one, the rapporteur session that we had of track A, B, C, D, E, F is usually the longest, because they have to report what has been happening in this conference. That's why we allowed them. Some were reading verbatim, some were reading from off the cuff, but they were important that they present exactly what happened in each track. And I would like to recognize and thank them for that particular. So essentially, we've had 5.5 days of discussion on HIV, TB, and malaria. And this was based on science. You heard people talk about pre-exposure prophylaxis. and post-exposure prophylaxis. I think those things are not being talked about enough in the region. They're effective. There's still stigma about it. People don't want to be known that they're on pre-exposure. And they don't want even to be known that, I've been exposed, I had condomless sex last night. They want to go and buy surreptitiously, or are so ashamed to go and buy that they don't buy the appropriate medication. So those two areas, because of the stigma, which you must fight, science is saying, these things work. So we've been here on science, we've been here on leadership. And when I talk about leadership, it's not just at the high level, it's at the lowest level as well. But more importantly, it's at the policy level. It's policy, that's what's called leadership. What policies have you put in place to make this issue a success? And finally, we've talked about the community. And you saw that there were people who spoke very, very passionately about the community. And I think that was useful for us. So, participants, I would like to declare that this conference was a resounding success. I'd like to declare that it was a resounding success. I'd like to say so because not only were the first ladies there, but we also had two presidents who came. We had two vice presidents who came. We had ministers who came, including our Minister of Health who came. Now we're having Minister of Foreign Affairs of the whole country coming. I think that in the whole UN system was in full force, including Winnie Binyame. She was here from UNAIDS. I think that is something that we must really applaud. In the end, we had 8,180 participants, both virtually and in person. And that's a big conference. And why I'm proud of it is because now ICASA is the most influential AIDS platform on the continent. It is definitely now dominating, so it must do well. We must do well. It is, in fact, really a leading component of how we fight HIV and AIDS. But what is also important is we now at SA, together with those directors, we devised now a new system of having these conferences. We said, no, instead of people starting at 7:45, 7:30, and have a plenary at 7:30, I've seen it in many conferences when I go out. You are rushing there to a plenary. We said, no, let's have a real plenary at 9:45. And now this has been very successful. And we have said all plenaries should end by 4:00. You can have other meetings to drink into that, but those are the main ones. And we've seen that those are important, and it has been successful. Because you see, our span of concentrating is very short. So if it's too long, people start going to the toilet, so I think it is important that we limit the times. Community Village has been successful. It was a hive of activity, hive of discussion, hive of displays, hive of activism, and we allowed it to happen. The exhibition center, we had a lot of exhibits here, honorable guest of honor, and we had 105 booths. Very successful, people going there, studying what's happening, and I think that is what ICASA should be. So finally, I would like to thank, like I said, our president, the people of Zimbabwe. They've been very good, the people of Zimbabwe as usual, because I saw a lot of you in the nightclubs there. I was embarrassed. You were there, and you were being welcomed, and that is a very good sign of us. The UN system, let me thank you very much. A lot of non-state actors, let me thank you also. The service providers who have made all these ambience possible, we want to thank you very, very much. The conference center, this particular conference center, the owners of it, want to thank you, which is government and people who run it. Rainbow Hotel, let's thank you too. The communities mostly, they've come from all shades of community. I would like to thank you. The National AIDS Council of Zimbabwe and your team, let me thank you very much. You were the local secretariat. I want to thank the ICASA secretariat that are based in Ghana, and they're fully here, they're all here to assist us. I want to thank them very much. The media, they were not harassing us, but they were nicely aggressively harassing us for information. I want to thank you very much. And what has come out has been positive in terms of fighting HIV and AIDS, and that's how it should be. There was a group of volunteers. Let me thank you also. The rapporteurs, let me also thank you. But especially Avacare and African CDC, they gave $1,000 each to those who got awards yesterday, the day before, and so on and so forth. Each one was getting 1,000. And I think we want to thank them that. I would like to thank Gilead. Gilead has got a big stand out there. They gave us 500 US each for 20 women who are health workers. And I would like to thank them that. They have promised that next time it will be 500 US for 20 men health workers. So it balances. Let's thank them that. We had reviewers of our abstracts. Those worked very hard. You know, those abstracts, when they come out, they must be of top scientific material so that they can stand anywhere in the world. We should not see ICASA as second grade. It should be really standard. And we had 120 reviewers who reviewed our abstracts. I'd like to thank them very, very much. Various presenters, various chairs, coordinators, I think that they did a brilliant job. This ICASA is African-led, and now we are seeing it's the participants are African. The scientists are African. And that is what it should be like, so that we begin to put our steps in the right way. Nine networking zones, want to thank them very much. Our translators, including sign language, I don't know whether it's always correct, but I've seen this. I want to thank you very much too. You're doing a great job. But you see, there was a board of chairs and co-chairs led by Professor, you know, we divided this into science, leadership, and community. And those groups had chairs, and those chairs worked extremely hard with their teams. So Professor Morenike was the chair of the scientific committee. Professor, can you just stand so that you are seen? And the co-chair from Zimbabwe, because we always have an international chair and a local co-chair. And the local co-chair is Professor Javahera Mike Chirenji. Could you also stand, please? Thank you very much. Now, the leadership committee was led by Dr. Thiem. Please, can you stand? She's a former Minister of Health. I want to recognize you. She was leading the leadership committee, and Dr. Owen Mgurungi was the co-chair. Owen? I saw him here, but Dr. Mgurungi is really one of the gurus here in terms of HIV and AIDS. Then there was the community. A committee was led by Lillian Moreka. Lillian, there you are, at the back there. Let me thank you. And she was co-chaired by Jimmy Wilford. Is Jimmy here? Okay. So, what are the next steps for SAR? We are going to launch an annual journal at the second quarter of next year. That's going to be important because we're moving with science, and we'll put it virtually, we'll put it all across the media. That's going to be very important. We will be disseminating what we just heard here to all the 5 regions of Africa. So we'll go personally to each region, together with the executive director and some of the board members, to launch this so that we begin to synthesize activity and interest in fighting HIV in the various regions of Africa. We will meet again as ICASA in December 2025, but at a country we will announce before, by March. There are others who have already bidded, whom we've already assessed, but after this conference, when I went around, the number of people who are now saying, we want to host, I think they've seen what hosting can do. They're now saying, can we host ICASA? So we've reopened the bid. Say, okay, we'll reopen the bid for countries until the end of January. If you really want to host, give us that bid and we'll come to your country and assess and then say, yes, this is suitable for us. Finally, I hope that we can start a degree or a diploma in implementation, because there's a lot of things that we talk about and we don't implement. Maybe we should have real implementation postgraduate to see how we can implement what we talk about. And that will be going to be very critical for us. Thank you very much all. I hope that you have safe journeys, and remember that ICASA is for you and for the people on the African continent to lead the fight against HIV on their own continent. Thank you.
OK, merci Monsieur le Président David. Et on va passer à l'allocution suivante. J'ai l'honneur d'appeler l'honorable Douglas Mombeshura, ministre de la Santé et de l'Enfance au niveau du Zimbabwe, pour venir magnifier le leadership du Zimbabwe et faire son mot et introduire notre invité d'honneur, qui est Monsieur le ministre des Affaires étrangères. Monsieur Douglas, vous avez la parole.
Good afternoon. Good afternoon to you all. Yeah, awake. It's very easy to fall asleep because we've been here for quite some time. Let me start by recognizing our guest of honor, the Minister of Foreign Affairs and International Trade, Dr. Frederick Shava. Let me also recognize Dr. Pagwesese David Parenyatwa, who is the President of the Society for AIDS in Africa and the ICASA 2023, and all the board members who are here present. Honorable ministers and deputy ministers here present, all UN agencies here present, members of the diplomatic corps, senior government officials, Dr. Madzima and all your team from NAC, who have been running around to make this event a success. Participants to ICASA 2023, scientists and all presenters who are here present, members of the media, distinguished guests, ladies and gentlemen. You will agree with me that we have had a very exciting week with pleasant sharing and exchange of knowledge, information, and progress by scientists, academics, researchers, programmers, activists, people living with HIV, business and senior leaders of government, and other key stakeholders from the continent and beyond, all brought together by the common desire and commitment to end AIDS. We had a very rich program comprising 15 plenary sessions, one high-level meeting of the African First Ladies on ending and addressing the prevention of mother-to-child transmission and elimination of newborn infections in Africa. This high-level meeting took place in Victoria Falls and was organized jointly by ICASA, Government of Zimbabwe, and the Organization of African First Ladies for Development, OFLAD. We also had 78 oral abstract presentations, 19 non-abstract driven sessions, 13 special sessions, 8 workshops, 32 pre-conferences, 77 satellite sessions, 27 community village sessions, and 813 abstract posters, as well as nearly 480 speakers. As you can see, this was a massive conference. This has indeed been a supercharged week. As the Minister of Health and Child Care in Zimbabwe, I can confirm that the conference has brought up some interesting insights that will shape our health and HIV response. The conference reminded us that AIDS is not over, and we must remain vigilant to ensure we effectively truncate and achieve the Sustainable Development Goals by 2030 without leaving anyone behind. Spectacular as it may have been, we have to recognize that the conference is coming to its end and we must say goodbye. We need to make friends and connections, but still we must say goodbye. It is my fervent hope that the friendships and connections we have made will be long-lasting and positively impact the continental and global responses to HIV. I hope that we will go back home and implement what we have learned at the 22nd edition of ICASA to edify the response to HIV, Ebola, and other epidemics. Ladies and gentlemen, allow me to introduce the Minister of Foreign Affairs and International Trade, who is our guest of honor for the closing ceremony, to deliver his official closing remarks. Honorable Minister Dr. Frederick Shawa is a very long-serving member of the government of Zimbabwe. He has been in the civil service, in the diplomatic service, and is also a very seasoned politician. Upon the attainment of independence in 1980, Minister Shawa was appointed Minister of Labor, Manpower Planning and Development from 1981 to 1986, and Minister of State for Political Affairs in 1987. He has also served as Zimbabwe's representative to the United Nations, where he was the president of the UN Economic and Social Affairs Council. His career also took him to China, where he served his country as the ambassador to China from 2007 to 2014. The minister has held his current post of Foreign Affairs and International Trade since 2021. Over to you, Honorable Minister, to address the crowd. Thank you.
Thank you very much, Dr. Mombeshora. The Minister of State for Provincial Affairs and Devolution for Harare Metropolitan Province, Honorable Tawengwa in absentia. The Minister of Health and Child Care of Zimbabwe, whom I have already addressed. The Executive Director of the United Nations Population Fund, Dr. Kenam, the Executive Director of UNAIDS, Bianyima, Society for AIDS in Africa and ICASA 2023 President, Dr. Parire Nyatwa, other Honorable Ministers of Health from Africa who may be here, Chief Secretary for the President and Cabinet, Dr. Martin Rushwaya in absentia, senior government officials, Regional Director for Africa, World Health Organization, Dr. Moweti, development partners who are here present, distinguished conference delegates, members from the media fraternity, ladies and gentlemen, good afternoon to you all. It is indeed my singular honor and privilege to address you today as we prepare to conclude the 24th International Conference on AIDS and STIs in Africa, whose theme, and I quote, just to remind you, AIDS is not over. Address inequalities, accelerate inclusion and innovation, unquote. I would like to express my sincere gratitude to all the participants who have dedicated their time and expertise to this very important event. Over the past few days, stakeholders have engaged in meaningful discussions, shared knowledge, and explored innovative approaches to combat the HIV/AIDS, other sexually transmitted infections, and emerging epidemics in Africa. What has been very, very clear from the onset is that AIDS certainly is not over and should remain on the priority list of governments, partners, donors, communities, and all stakeholders. It is our hope that the outcomes of this conference will generate incisive research, influence policy development, and lead to implementation of effective prevention, of effective treatment, and ultimately eradication of the epidemic. Distinguished guests, ladies and gentlemen, as we come to the end of this conference, it is crucial that we reflect on the progress we have made and acknowledge the challenges that lie ahead. Indeed, great milestones have been achieved in this fight against HIV/AIDS and other sexually transmitted infections, as well as Ebola and other emergencies. While we celebrate the significant advancements achieved, we must also remain vigilant in our quest to eliminate these diseases from our society. As Africa, let us continue to invest in strong health systems that provide accessible and equitable health care to every individual, regardless of their socioeconomic status or geographic location. The fight against HIV and AIDS, STIs, and Ebola should not only focus on medical interventions, but also address the social determinants that fuel the spread of these diseases, such as poverty, gender inequality, and stigma. In so doing, it is important that we leave no one behind and promote innovation to solve the problems. Ladies and gentlemen, His Excellency, the President of the Republic of Zimbabwe, Dr. Emmerson Dambudzo Mnangagwa, in his opening remarks at the beginning of this conference, implored on the need to support indigenous medicines, harnessing the vast natural resources that Africa is endowed with. Therefore, a vibrant African traditional medicines, pharmaceutical industries should be put in place so that we have scientifically viable medical products tailor-made. Intra-Africa collaborations and partnerships should be upscaled as we advance our response to the fight against HIV, AIDS, and other emergencies. The responsibility to build our continent and to resolve its challenges lies in us, hence the mantra, African solutions for African problems. Therefore, we disperse from this place. As we disperse from this place, let us explore the various opportunities that lie in our African God God-given resources, the flora as well as the fauna, amongst others. Truly, together, we can make a real difference. Ladies and gentlemen, the conference has reminded us of the importance of implementing comprehensive and evidence-based prevention strategies that prioritize key demographic groups that includes young people, sex workers, and people who use drugs. And by adopting a multi-sectoral approach and involving all stakeholders, we can create an enabling environment that fosters healthy behaviors and empowers individuals to take control of their sexual and reproductive health. Ladies and gentlemen, I am particularly encouraged by the emphasis placed on strengthening community engagement and involvement. Community-led responses have proven to be effective in raising awareness, reducing stigma and discrimination, and improving access to prevention and treatment services. Let us support and amplify the voices of those who are most affected by HIV and AIDS, STIs and Ebola, so that their lived experiences can also shape our policies and indeed our interventions. As I conclude, I would like to express my deepest gratitude to the organizing committee, the sponsors, and all the volunteers for working tirelessly to make this conference a success it has been. I also extend my appreciation to our international partners for their unwavering support in our fight against HIV, AIDS, STIs, Ebola, and indeed all other emergencies, as our memories of the losses we suffered at the hands of COVID-19 are still very grim, yet fresh. We feel truly privileged as Zimbabweans to have hosted you. It is my fervent hope that you will leave this conference inspired and energized to continue work in your respective countries, united in our commitment to achieving an AIDS-free generation. Together, we can build a future where no place and no one is left behind, as we all enjoy good health and well-being. I want to wish you all safe travel as you return to your countries and homes. Ladies and gentlemen, Merry Christmas and a prosperous 2024 to you all. And Jenny Mercies, thank you.
Thank you.